Okay. Hi, good evening, everybody. Thank you for coming to this webinar, the first after Chinese New Year. We stopped for a week or two, and the response has been really good. I think the thing is, we never had an orthopedic surgeon that spoke about sports injury. So this is our first in the last 2 years. And for all the nurses, I would appreciate it if you can go to Facebook Live, because we have too many doctors trying to come in, and there's no more space because I only allocate about 100 because I only paid for 100. For all the doctors, if your friends are asking, they can actually watch from Docquity. So I have my colleague from Beacon, who is actually you do sports medicine, right?
I'm a sports surgeon.
You're a sports surgeon. Are you a sportsman yourself?
Well, I do. I walk, I cycle, I swim sometimes, but I'm not really good at it.
Okay, but you don't do competitive sports in that sense?
No, I don't do competitive sports, no.
Okay, so you basically do mainly sports surgery.
Correct.
Okay. So and he's also a content creator. He watch out, go and see his Facebook and TikTok. Quite amazing work, I would say. I always watch them. So without further ado, please, maybe you'd like to share your slides, and we can go ahead.
All right. Okay. There we are. So do you see the cartoon, Betty?
Yes.
You do. Okay. So shall I begin?
Yes, you can start.
All right. Good evening, everyone. And it's really a pleasure to be here and to meet all of you, although I can't see all of your faces, but I can imagine you there, and that's a real blessing for me. I'd like to say thank you to Dr. Betty as well, not just for inviting me here, but also for taking such good care of my patients when they have heart problems, and putting them back onto their feet, and some of them have been able to go back to sports. And thank you so much for that. My name is Putra. I'm an orthopedic surgeon in Beacon Hospital, and I think sports is something that we should be talking about more, because it's my personal and professional motto is to live is to keep moving. So I think that if we don't move, if we just sit in one place, actually our body tends to fall apart, because we are created with 2 hands and 2 legs to move. So it's really important to keep moving, and sports is a great way to do that, to keep yourself healthy. Now, I'm not sure whether I can see the participants typing things? I can, right?
Yes, you can. From the chat, you can.
Okay. So can I ask a quick question? Can you guys just type in, some of the sports that you do? I've given a talk like this before, and the most interesting sports that someone has participated in is ostrich racing. Now, I don't know whether any of you guys have done that. I don't know how that happened, but apparently someone did that. So can some of you just type the sports? I'll try to start, so I'll just put there cycling, which is something I do occasionally. So can we give about 10 seconds for that?
Okay, I do diving. I don't know whether I do swimming, which I started learning, and I do running.
Wow, okay.
And also hiking.
Okay, all excellent sports, and some of them there are risks to develop some sports injuries. So I think it's a relevant talk, because I think nobody else has written anything yet, but I'm sure that there are many sports people out there. So okay, let's go into the talk. Now this is just some information on who I am. My training is in orthopedic surgery and sports surgery and arthroscopic surgery. And I think that picture there shows what Beacon Hospital actually wishes that I look like. But most of the time, if you come and look for me in the hospital, I probably look more like this.
Unshaved and this is tired and
well, all covered up in the gown and all that kind of thing lah. And this picture shows an arthroscopic surgery. And, laparoscopic surgery is something that many people are familiar with. Arthroscopic surgery is getting more popular. Just for some history, actually, laparoscopic surgery has been around since 1901, which is about 120 years of laparoscopic surgery. Arthroscopic surgery is not so far behind. It started, depends on which paper you read, but it started somewhere around 1910, 1912. So it's been there, it's not something new. And one thing is I get some questions, why do arthroscopic surgery when it costs more, but there are benefits to it, and I summarize them as F, A, and Q. What F is the function is better. The patient goes back to function pretty quickly compared to open surgery. A is aesthetic, as you know, there are smaller wounds. Patients always like smaller wounds when possible. And Q is quality of life. So after going through arthroscopic surgery compared to normal open surgery, the quality of life is much better because the healing is faster. So that's just some information on why arthroscopic surgery is an upcoming field that I think is important. Now, today is Wednesday, by the way, which is smack in the middle of the work week, and it's kind of my favorite day of the week. The reason is because it's not yet the more tiring days at the end of the week. At the same time, we are close enough to be thinking about what we should be doing on the weekend. And when you imagine that a sports surgeon, what kind of patients a sports surgeon treats, probably you might be thinking of someone like my patients would be someone like Dato' Lim Chong Wei or Nicole David, or maybe someone like Lionel Messi or something like that. But the reality is the majority of patients that I see are what we call the weekend warriors. And I think that almost all of us come under the category of weekend warriors because we sit at our desk or in our jobs most of the week, and suddenly on the weekend, we burst out, we go and do all sorts of things. We hike, climb mountains, and play tennis, play all sorts of games. And the problem is that when our bodies are sedentary most of the week, and then we suddenly launch out into this kind of very aggressive activities, they tend to push our bodies to the breaking point, and that's when injuries happen, like tendons snap and bones break and things like that. So the weekend warrior is someone who's sitting at a sedentary job most of the week, and suddenly they go out and do something without much preparation. This is when most injuries happen, and I think it's important to look at this kind of group of patients more than elite athletes, at least when it comes to our practice in Malaysia. So as I told you, I am one of these weekend warriors myself. So that's myself and my wife. And when my wife, especially when she goes to a new place, like over the Chinese New Year holidays, we went to her hometown in Sarawak. So what she did is she Googled like the 10 best places to eat sampua mee, for example, in Sarawak.
She's Chinese, If you have not noticed, that's what we do.
Yes. So I did the same thing. I Googled like the best places in KL to go for sports. And encouragingly, there's this list that shows the best places to go for various things. Why am I bringing this up? Because I think it's really important when you start your sporting activities to get guided properly and to really go for a systematic introduction to this sport instead of just going directly into doing it without any guidance. Because when you go without any guidance, especially for the weekend warrior, that's when you tend to get in trouble. That's when you tend to get injuries. So I would encourage all of you, if you haven't already, taken up any sport, there are lots of good opportunities here. Feel free to Google it and check it out. But let's go to the common sporting injuries, which is actually the topic of today's talk.
Yeah.
And, where do we start?
A lot of people have replied to your questions. And
is it? Let me
some
see.
people even play field hockey. Usually play field hockey. Some people do ultra marathon. Suraya does that, and Fakaruddin does volleyball and gymnastic activities, and Karen does running and marathon. Amazing!
Wow! Thank you very much for the feedback. I love seeing this because I see so many different things that I never thought about, and sometimes that kind of inspires me to try out something new. So thank you, all of you. coming back to the common sporting injuries, where do we start? I mean, if you fall from a bike, the whole body, any part of it could be injured. But when we talk about the common injuries, we have to look at which parts of the body move the most. That's where most of the injuries happen. And we are talking mainly about the limbs when it comes to orthopedic surgery, as you know. So if you talk about the upper limb, the hand, the most mobile parts are the shoulder joint, the wrist joint, and the elbow joint. So that's where most of the injuries happen. And we're going to look a little bit more in depth about this. When it comes to the lower limbs, the most mobile areas are the ankle, the knee, the hip. So these are the common areas where injuries happen. Now, when we look at a part of the body, when, for example, if you look at an arm or a leg, you can peel the skin away and look inside, and you will find that there's muscle, there's tendon, ligament, bone, and things like that. Generally, I like to divide them into the bony or the hard parts and the soft parts. So we'll approach it from that point of view. So this is an X-ray. So I think majority of people here have definitely seen someone in your practice who has had a fracture. Whether you're in a clinic running a general practice or whether you're in a hospital, you definitely would have seen at some point. And sometimes it's quite straightforward. The patient comes with an ankle pain, for example, you do an X-ray and you see an obvious fracture there. Like the red arrow, you can see a spiral fracture of the lateral malleolus. Sometimes you have to look a bit harder. You can see the yellow arrow there, shows a tiny fragment coming off the medial malleolus. But generally, fractures are rather straightforward. And you know that when you have a fracture, the options for treatment will be things like putting on a cast. And nowadays, we have some slightly more high-tech gadgets like the one you see in the picture. We call this a VacoPad or a Air Walker or what have you. There are many brands. The good thing about it is that you can take it off, the patient can take it off to clean their limb, their skin, and all that kind of thing. But that can be a bad thing as well, because sometimes patients take it off too often and then the injury doesn't heal as well. In fact, in some countries, they have a lock for this where the doctor can actually lock it and keep the key in his office or her office, and the patient can't take it off, and kind of the patient is in prison in that booth. But that's almost the same as a cast. So this is something new, something rather
you lock
new.
it and they cannot take it out. How to scratch if it's itchy?
But Betty, don't you think when you put on a normal POP cast, they can't take it off anyway? So it's the same, right?
True.
It's just the fact that you put the lock there, they get a bit more scared, that's all. So, okay, I want to bring up something important, I think, especially for those in general practice, because it's not always that you have an X-ray machine available. So how is there any specific way to determine should I do an X-ray for this patient or not? Now, we're talking about ankle injuries. Now, these guys in Canada actually came up with this thing called the Ottawa ankle rule, where when the patient comes with ankle pain, you actually palpate the certain points on the ankle. So there are 4 points. One is the lateral malleolus, and up to 6, you can see it on the picture, up to 6 centimeters above. One is the medial malleolus and up to 6 centimeters above. The third is the base of the 5th metatarsal, and the fourth is the navicular bone, which is right where you palpate your dorsalis pedis pulse, just next to it. So if any of these points are tender or painful, that's when you will do an X-ray. I think that's quite important, because sometimes you do struggle to decide, should I do an X-ray? Not everyone should have an X-ray. Of course, if they want to do it, if they can do it, that's fine. But this is a good way to decide who does not need an X-ray. Now, sometimes casts are not enough, and we have to subject the patient to some surgery. That's most of the time when the fracture is badly displaced. Now, you might think that as an orthopedic surgeon, I might want to fix every fracture, but that's not really true. Actually, reduction is the most important thing. So if the fracture cannot be reduced, that's when you do surgery to fix it. So they're still talking about the hard part, which is the bone. And the second thing that happens is dislocation of the joint. Now, when two bones meet together, that's what we call a joint. And the joints that are the most stable in the body, they don't dislocate that much. But the ones that are really, really flexible, like your shoulder joint, which can move all around the place, like your hip joint, those are the ones that get dislocated. And I'm very sure that almost all of you would have actually seen a patient with shoulder dislocation at some point in your career. The shoulder is the most dislocated joint in the body. It's not that difficult to treat a shoulder dislocation, and this is one of the many methods to reduce a dislocated shoulder. It's called a traction counter traction method. It requires two people. You can see one to pull the patient's arm and one to pull the rest of the patient in the opposite direction. But there are many different ways that you can use to reduce the shoulder dislocation, which you can find online. There's hundreds and thousands of videos on YouTube that you can see. Once it's been reduced, the patient goes into either an arm sling or some kind of sling that's like the one in the picture. But the important thing is that when you have a patient with a shoulder dislocation, it's really important to try to avoid getting a second dislocation. Betty, did you want to say something?
I wanted to say something. Do you not need sedation or anesthesia for reducing this dislocation?
Okay, good question. In most cases, we will give sedation. Not always anesthesia, but usually sedation. But patients that have had dislocations, multiple episodes, some patients come in and this is their 11th dislocation of the same shoulder. Those, they usually don't require much pain relief because the shoulder has already become very, very loose. And that's the point that I was trying to make, is that when you have one dislocation, the risk of dislocating again is about 80 to 90% or more, depending on the age of the patient. The younger the patient, the more the risk of getting another dislocation in the future. So how do you prevent the second dislocation and the third dislocation and the fourth and the 100th dislocation? You strengthen the muscles around the shoulder. It can be anything as simple as just some internal, external rotation exercises that you do on your own. And you can see that on my website where I put some exercises for that. But I would recommend that you get the patient to a good physiotherapist to strengthen their shoulder muscles to prevent further dislocation. Now, let's look, because shoulder dislocation is so common, let's look at some x-rays. Now, commonly, when you do an x-ray in a dislocated shoulder, you don't really see much. But sometimes if the shoulder has dislocated again and again, then the components of the shoulder, the bones in the shoulder actually start getting damaged. And you can see that on the left here, there's a yellow arrow pointing to a small bony fragment on the glenoid that is called a Bankart lesion. And on the right, you see another common lesion in repeated shoulder dislocation that's called a Hill-Sachs lesion, which is basically the bone has been eroded after multiple episodes of rubbing against the other bone. The glenoid is basically digging out some bone from the humerus, the head of the humerus. And that makes it much easier for the patient to have a dislocation again, because it destabilizes the whole joint. So these are things that you can look for on the x-rays. Of course, sometimes you need an MRI, and maybe we may not go into all the details, but the red arrows show what is a soft tissue Bankart lesion. There's a small tear in the glenoid there, on the labrum there, which needs to be repaired. And I'll show you a little bit more on that. So this is how it's done. It can be done nowadays arthroscopically. It's quite straightforward, but again, the message that I'm trying to get across is, if you don't prevent the patient from dislocating their shoulders again and again, at some point they probably need some kind of surgical repair of their shoulder. So it's important to avoid repeat dislocation by strengthening your shoulder muscle. That's the message I'm trying to get across here. And sometimes, patient comes in with some pain, you do an x-ray and everything looks quite normal, and then the patient is like, doctor, why am I having pain? My x-ray is totally fine. And in the past, when I was working in the primary care setting, in the A&E setting, I used to label this as what we call a STI, or a soft tissue injury. Now, I think STI should not be used to make a diagnosis. STI should be reserved for sexually transmitted infections only, but not for soft tissue injury. Because soft tissue injury is a very vague thing, and you can't really get to the bottom of, you can't treat something until you get to the bottom of what's wrong in it. And thankfully, nowadays we have this device, which is we call an MRI, which is pretty widely available and very straightforward. There's hardly any side effects because it uses a magnet. It's not using radiation and things like that. Almost anyone can get an MRI. The only downside to it is probably the cost is definitely slightly higher. But it does enable us to properly visualize where the problem is. Is it on the ligament, meniscus, cartilage, or muscle? And we'll go through some of the common ones, not all of them. So let's start with something that probably most people who have some exposure to sports have heard about, which is an ACL tear. Now the ACL is a ligament in the knee that holds the femur and the tibia together, holds them stable. So when you walk and you run, the bones don't get subluxed. It keeps your knee stable as you run, especially as you run and change directions, like when you're playing football. So many famous footballers have had this injury. You usually see they go out of action for about 6 months or so, and then they come back and start scoring goals again. So that's probably an ACL injury. Now, that's what an ACL is, but the patient doesn't necessarily feel pain. What the main complaint in an ACL injury is instability. So the patient says, doctor, when I run, I feel that my knee is very wobbly. And especially not when I run in a straight line, but when I run and I pivot or I change the direction, that's when they start to feel that their knee gives way. They may feel like they are going to fall down. But if you ask them, do you have pain? They'll say, no, I never had. I didn't. They might even forget that they had a fall. Usually this happens when you land on a knee in a bad angle and you twist your knee. That's when you get an ACL tear. But the patient may have actually forgotten all about this injury. So you have to probe them and ask them, was there ever a time when your knee swelled up and you were not able to walk properly for a few days? Then they will say like, oh yeah. Now that you asked about it, there was an episode 2 years ago that I had this, and that's usually when the injury actually happened. So the key is that there's not much pain. It's more of an instability, a wobbliness of the knee. And the first and the most important treatment actually is rehabilitation and exercises. As you can see, I put up this slide. This is from my website, and it shows my wife, demonstrating some exercises there. You can always check it out. There's exercises for different joints, but the key is in ACL injuries, the mainstay of treatment is still exercises, unless you are a serious athlete, and that's when probably we'll go for the next thing, which is to do an MRI and go for things like surgery. Now, this is what an MRI looks like in a normal ACL. So most ACL injuries, you can't really see it on the X-ray because the ACL is a soft tissue. But there are some things that you can pick up on the X-ray, which I will show you a bit later. But this is what an MRI looks like. And you can see that yellow line is a normal ACL. Now I put up a torn ACL, and you can see that the clear dark line which goes across has been lost. It's kind of very fuzzy and unclear. If you measure that, usually a normal ACL is about 1 centimeter in diameter. So if it's more than that, you probably have an ACL injury on an MRI. Now, let's look at X-rays, because I think X-ray is widely available. You can't see the ACL tear itself. However, this X-ray actually, when I first looked at it, it looked really normal to me. But if you look closely, just right at the joint line where the arrow is, just above the fibula, there's a tiny fragment there which we call a Sagon fracture. Now that is, I believe the word is pathognomonic, which basically means when you see that, that means it's equal to an ACL injury. And why this happens is because the ACL holds the bones together, but once the ACL has torn, it allows the knee to rotate and the capsule tears at that area and causes this minor fracture which you see on the X-ray. So if you want to take a screenshot of this, you should, when you have a patient with a knee injury, do an X-ray. If you don't see any injury, look hard at this area. It's called a Sagon fracture, and it's equal to an ACL injury. ACL injuries mostly are injuries of the ligament, but sometimes the ligament can pull out a piece of bone, and we call that an avulsion fracture. So if you look at this X-ray, you see that along the joint line, there's suddenly a small fragment that looks out of place, and that is an avulsion fracture. So these are things to look out on the X-ray. It's not always something very obvious. Sometimes these injuries can present with minor changes on the X-ray. So do be aware of that. Let's go to the treatment. So yeah, so I was telling you the mainstay is rehab, but sometimes the patients have to go for surgery. And this was during the days that I didn't really have a very nice cap to wear in the operating room. Nowadays I have a nicer looking cap. But let's look at how the operation is done. Sorry, Betty, I can't hear you.
Oh, go back to the previous picture, please.
Yes.
Do you use a camera for this picture? The lighting, everything, the color is amazing.
Thank you. I really have to refer you to my OT staff, which are excellent photographers. I don't know how they do it, but they take wonderful pictures.
What do you mean? They use what camera? The iPhone,
Yes,
the phone camera?
I believe it is a Huawei phone, I think.
I see.
Yes. So perhaps I'm not doing a promotion for Huawei here, but you can check it out if you
Yes,
like.
because I have been actually checking out your social media content in your Facebook, and I'm really impressed with all these pictures. And of course, you are very meticulous in trying to make people understand everything. So you have part 31, part 32. It's really a lot of work, and it's amazing. Well done.
I think it's thank you. I mean, it's been going on for some years, so it's kind of like a, I guess it's a labor of passion lah.
Yes.
You could call it that.
Content, right?
Okay. So we are talking about ACL surgery. We cannot repair a torn ACL because the ACL is a ligament that floats around within the joint. If you repair it, it will never recover. So what you have to do is you have to reconstruct the ACL. How we do that is we harvest, or we take a tendon that we can consider it like a spare part. Usually it's a hamstring tendon. We remove that and we fashion it into a new ACL. We drill tunnels in the tibia and the femur and pull it through, and that becomes the new ACL. But what I'd like to highlight is, if you have a patient that's considering going for an ACL reconstruction, what they need to understand is that the surgery may take 2 hours and they may be in the ward for 2 days, but the rehabilitation goes on for about 6 to 8 months at least. And so they have to be really committed to that, because you really need a lot of rehab to strengthen the new ACL, to strengthen the muscles around the knee, and that is a big commitment. So the patients do need to understand that. This is just to show you how we repair those. I showed you the X-ray earlier, the avulsed ACL, avulsion fracture of the ACL. We used to use screws, but those have well, they cause pain, and we have to remove the screws later on. Nowadays, we use these soft anchors and buttons to fix it down. It can be done using the arthroscope as well. So we were talking about the ACL. We're going to meniscus tears now. Now, the meniscus, as you probably know, is like a soft structure within the knee. We call it, if we use lay terms, we call it a shock absorber of the knee lah. And it's really important, because when we run and jump and all those kind of things, all that weight that our body has is being absorbed by the meniscus. So when there's a tear in it, it's not surprising that it's painful. And what I'd like to talk about is an emergency. Well, I mean, some people have the idea that orthopedic cases are rather cold cases, and there's nothing really emergency about it. But the locked knee is something that is an emergency, because what happens in a locked knee is a torn meniscus gets stuck inside the knee, and the knee, from being able to move freely, suddenly gets jammed in one position. That is an emergency, because if you leave it in that position, the structure that is jamming the knee, which is the torn meniscus, actually can damage the cartilage and cause really bad arthritis in the knee. So it has to be repaired. It has to be addressed surgically almost all the time, and usually within a few hours to a day of the injury. So this is something quite important, locked knee. Now, this is how a meniscus repair is done, just to show you some photos. And it's all done arthroscopically. We don't open up the knee. There are newer devices. These are using sutures, but there are newer devices that can be used, like staplers. There are many different brands, like we call them fast sticks or whatever. But essentially what we do is we stitch the meniscus together. Now, you may have heard of something called the bucket handle tear, which is quite a famous tear. Yes, Betty?
Okay, sorry. I want to ask you, why is this locked knee an emergency. Can it wait until
Okay.
tomorrow?
Usually we'll say that it needs to be addressed within 24 hours. Within 24 hours. The reason is because if the knee is locked in one position and the meniscus which is torn is slipped in, it is eroding on the cartilage. And the longer you leave it there, it damages the cartilage.
Okay. Okay.
And well, I mean, it's not going to, no one's going to lose their life over that.
Yes.
But their function may be seriously, impacted in the future.
Okay, I understand.
Yeah. So that what Dr. Betty was talking about, the locked knee, actually happens most commonly in what we term a bucket handle tear. But I want to talk to you about something that's more subtle. Now, if you look at this picture, you see that the meniscus has, this is, if I can point, there's a front and back of the knee. Usually the back of the knee, there's a structure which we call the meniscus root. And that's where the meniscus comes and attaches to the bone, and that's a really important part of the meniscus. And this paper by Robert Lappard, who is kind of the biggest surgery today, and it's not a very old paper, it's quite a new paper, says that there's a silent epidemic, which is a meniscus root tear. So what is this? Let me just show you what I'm talking about. So in our culture in Malaysia and in Asia, especially like in Japan, Korea, and all these places, it's very common to find people sitting in this position. A kneel sit, they call it. Okay, you're basically sitting with your knees on your knees. And I think in our culture, we tend to see it as something quite a polite way to sit. And it definitely is used in prayers for the Muslims especially. And the problem with this position is, if you're just doing it once in a while or during prayers, that's totally fine. But if you keep on sitting in this position, then it puts a lot of pressure on the back of the meniscus, on we call it the meniscus root, and it can cause tears which tend to progress. And when the meniscus root tears, it's really bad because it causes very severe arthritis of the knee. So this is a small video I prepared to show you what a meniscus root tear is. So you can see there's a floating fragment there, and that's the meniscus root. And this is how, if you miss it, don't worry, you'll see it in a bit. So what we do is we bare the cartilage there because we want to get a good bed for the meniscus to be reattached to. That floating fragment up there above the device is the meniscus root. So we drill a hole there, we pass a suture through it and pull an anchor into the bone so that we can anchor the meniscus into the underlying bone. So this is how a meniscus root repair is done. You'll see the anchor come in now. The anchor looks like a little fabric or a little suture structure that is anchored into the bone. And then we suture the meniscus and tie it down. This is a short video, will be done in about 10 seconds, I guess. These are the stitches being applied, and you see the root has been repaired and it's no longer floating up. So you can see that's the end of the repair. And well, usually it takes about 6 weeks or so for this to recover. Recently, I had a patient who she recovered quite fast, but she's in her 20s, so I guess age does make a difference when it comes to recovery. So we're talking about meniscus. Let's move to cartilage. Cartilage is a very smooth substance. In fact, it's the smoothest substance known to man. There's no man-made substance that is smoother than cartilage. And you can see that normal cartilage is what appears on the left of your screen. And then you have a minor damage and a major damage. Of course, if you have damage of cartilage in the entire knee, then we give a different name to it. We call it arthritis. And sometimes you may require a knee replacement like this X-ray here. If you want to see what it looks like in the operating room, that's roughly what it looks like here, where we open up the knee and we change the entire cartilage to something synthetic. But that's not always what happens, especially if you've got a tiny cartilage injury. So then what we can do is we can repair it. There are different ways to repair it. This is like a 10-second video showing you how we repair a small injury in the cartilage. So you can see that I've applied a kind of like a collagen scaffold onto the cartilage that is injured. Then we move the knee to make sure it doesn't dislodge, and then we check it and you see that it's repaired nicely. Now, what happens is it takes a few weeks, but the cartilage tends to regenerate in that area where we apply the collagen. So this is a cartilage repair. But sometimes if the cartilage injury is too deep or too big and we can't repair it, then we do something called a cartilage replacement. It's not a knee replacement, it's just a cartilage replacement. It's something quite new. I think it's been around in Malaysia for maybe 1 or 2 years now. And there are not that many cases that have been done yet, but I've seen one case that the outcome was pretty good. So I think this is the way of the future. It's not widely available yet. The other thing is for a lot of general practitioners, I know that you have been doing hyaluronic acid injections, and I think that's great. It's a good way to improve the lubrication of the knee when the patient has a cartilage injury. There are many ways to inject the knee. You can inject from different directions, so use the way that you're comfortable with, but this is the way that I use usually. This is from the lateral side of the knee, just below the patella, and I aim the needle up into the suprapatellar pouch, which is just above the patella. So I feel that that's the least painful way to do this injection for the patient. Of course, there's also things like PRP. PRP is increasingly widely accepted here. I use it quite a bit, and I think it's really good, not just for cartilage injuries, but also for things like tendon injuries, like in tennis elbow, and for various other ligament injuries, like the medial collateral ligament in the knee. So PRP is something good. I know that a lot of general practitioners have very, very creative ways of using this PRP, and I think it's a good method, and it doesn't cause harm because it's using the patient's own blood. So I think that's good. It's just that it's not yet been as widely accepted as hyaluronic acid or the gel injection. So remember, we talked about the top 10 lists, like top 10 food. I kind of prepared this top 8 list of the top 8 injuries in amateur athletes. So we'll go through them. If you have any questions, you can always ask about it. We won't go through it in too much detail. So let's go to number 1. So number 1 is ankle sprains. This is pretty common, especially in people who go hiking. So like Dr. Betty said, she likes to go hiking. I think that's, it's a hazard of hiking lah. Simply because you walk on uneven ground, and there's a tendency to twist your ankle. There are several ligaments that are commonly injured in the ankle, and you can see there's the ATFL or anterior talofibular ligament there, the deltoid ligament. What I would recommend is actually, if you do have an ankle, a twisted ankle, and you have pain, the best thing is if there is tenderness. Remember, we talked about some of the Ottawa ankle rules. If there is tenderness in those areas, do get an X-ray. But what I do to diagnose these ligament injuries is actually use an ultrasound, which I think is increasingly being used to look at ligament injuries in the acute phase. Because sometimes if you do an MRI in a very early phase, you don't really see you don't get much valuable information because everything is very swollen up. So the ultrasound is something relatively inexpensive, something that you can do on the spot, and you can detect injuries like this. The other tip that I would give to hikers especially is if you can get an ankle splint. It's widely available. You can get like a left or right side ankle splint. Keep it in your backpack when you go hiking, just in case you twist your ankle. You can put that splint on, and at least it gives you some support until you get back home and you get to the doctor. Okay. So that's something that's important.
Okay, I'll keep that in mind.
Okay. The next, so we're going on the top 8. Okay, so this is number 2 now. So shin splints is something very common in runners. They have pain at the shin, and sometimes if you do an X-ray, you might see a line that appears like a stress fracture, but usually it's not a stress fracture. It's just an area of injury, an acute area of injury of the periosteum. And it heals up very well with some analgesia, either some anti-inflammatories, and a bit of ice and just rest, which means that 2 or 3 weeks off running. So this is something very, very common. Okay, runner's knee. Now, the runner's knee actually is a simple term for something which we call iliotibial band syndrome. Now, the iliotibial band, I'll highlight it here on this slide. Is that white line that runs from this lady's hip up to her knee. And what happens in runners is that the iliotibial band keeps rubbing against the surface of the lateral surface of the femur, the bone, and it gets irritated. Now, this is easily treated with rest. It's treated with a little bit of a massage. So the physiotherapist can do that, but I've been teaching my patients how to do it. What you do is you put your hand, you measure a 1 hand breadth above the knee. You apply some anti-inflammatory gel like ketoprofen or Voltaren gel and ask them to do a deep massage there. And about 3 to 4 times a day for about 5 minutes. And usually it goes away, but it can recur again. So how to avoid doing this is to stretch properly before you go running. And that's really important for your knees and for your hips. Otherwise, you're at risk of getting runner's knee or iliotibial band syndrome. Tennis elbow is something I think everyone has heard about. Tennis elbow is the one on the outer side. Golfer's elbow is the one on the inner side. Just a reminder there. And now, it's not necessary that you have to play tennis to get tennis elbow. In fact, the majority of my patients are new mothers, those that have recently had a baby and they start, they carry their baby, they are so excited and they also tend to overuse their elbow. And bear in mind, it's not just new mothers, new fathers, new grandparents, babysitters. All of these people may come to you with elbow pain and they may not play tennis, and you may say that, you can't have tennis elbow because you're not playing tennis, but the reality is they can. These usually respond to a little bit of exercises. So you can do a little bit of a stretch like this using a weight. You can hold a weight in your hand and you can do a little bit of a side-to-side movement. That usually strengthens these muscles here and reduces the pain. But if necessary, you can give a little bit of PRP or a little bit of a mild steroid injection into the what we call the common extensor origin, which is at the lateral side of the elbow. Now, the rotator cuff, now we are at number 5, I think now. Rotator cuff it is actually 4 muscles that connect the arm to the rest of the body. So all your shoulder movements are basically controlled by the rotator cuff. And injuries to this are most common traditionally it is described as overhead activities, like sports like baseball and cricket, basketball, where you throw something over your head. But it is very common to see this in older patients as well, because there is a degenerative injury of the rotator cuff. So minor falls can cause a rotator cuff tear. I've had a young patient recently which had a fall and had a bad rotator cuff tear. So it's not just older patients, it's young patients as well. And this usually, you can detect this on the ultrasound. The good thing about ultrasound is dynamic, so you can actually see the movement of the rotator cuff tendons when you move the shoulder. And the other thing is that, again, rehab is important. As I told you, there are 4 rotator cuff muscles. If you injure one, there still are 3. So it's important to strengthen those 3 muscles to take over the function of the injured muscle, and that's how you treat these injuries. Also, if the patient is having too much pain and they're not able to move and do the exercises to strengthen their shoulders, then what I have been doing is I do what is called a radio frequency ablation of the suprascapular nerve, which is somewhere around here. That can be done under the ultrasound or under an X-ray, and it blocks the nerve that supplies the shoulder, so that the patients don't have pain and they are able to do the exercises. So what heals them is not the radio frequency ablation, it's the exercises, but the radio frequency ablation of the nerve is the step that allows the patient to do the exercises and get healed. So it's one step, it's not the only thing.
Sorry, the exercises heal the calf tear.
Okay. There are four rotator cuff muscles, right?
Okay.
So the way that you can think about it is, if you've got 4 friends and one friend is sick or is injured, so the other 3 have to work extra hard to cover for the friend while the friend recovers. Okay. So that's how it works. So rotator cuff tears, if they are not massive tears, they can heal. But what they need is they need a break. So you strengthen the other muscles to give the torn muscle time to heal.
I see. Okay.
So that's how it works. But if it's a massive tear, if it's like, torn apart, there's not much choice. You have to go in and repair it. And that's done arthroscopically as well. So it's not a major thing, but I think that no matter what, even if you go for surgery, you still have to do the rehab to strengthen the muscle again after it's repaired. The number 6 is hamstring injuries that you see in mainly in football players, also in rugby players. Now, hamstring tears can be anywhere from a small tear to a large tear. You can see there's a grading there. And the higher grades probably need something like PRP to stimulate healing. The lower grades, they heal quite well on rehab and rest. ACL tears, we have talked in depth about it, so I'm not going to repeat that now. Now, the last thing that I wanted to mention is we have talked about limb injuries, but there can be other things. There can be brain injuries, concussions. I don't treat that. You probably need to get a neurosurgeon involved. But it's important not to forget that when you see a patient with a knee injury, they may also have a brain injury. So you do have to be on the lookout for that, and spine injuries as well. So that's my list of the top 8 injuries in amateur athletes. I want to just take this opportunity to remind you again to, if you haven't gotten started in any sports, that there are various places that you can go to. So please do consider getting more active. To live is to keep moving, as I always say. And that is my website where you can reach me. You can always add me on Facebook. That's my Facebook account there. And if you have any questions that I don't manage to answer here, you can always hit me up on Facebook. I may not reply the same day, but I will reply. And if you have anything to discuss, just you're welcome to give me a call, give me an email or anything. My email and my phone number on that website anyway. So thank you so much, and I look forward to your questions.
Okay, we have some questions, and I want to say today the response has been crazy. So many people have been trying to come in, and the viewers reach about 500 in
Wow.
Facebook. Yeah, and it's just been amazing. So thank you for your support. We will, of course, as Beating Hearts, for me, I will try to improve. Sometimes it takes a lot of effort, so I'm very comfortable doing this webinar. Somebody asked me for a physical meeting on but I have to put in a more effort, and I'm working on my own. But maybe we will work something together, because maybe Putra can, he's young and he's capable. Maybe he can put up a workshop or something. Yeah. So we work together and see with even our hospitals. Our hospitals have been really supportive of the doctors doing social media content, educating the public and educating the healthcare workers and other doctors. So bear with us. Do you mind not sharing your slides so I can share the
Yes,
QR code? Let me share the QR code. So maybe you can have a look at the questions. Okay.
All right.
So this is hold on. Let me just. How do I do this? Okay. Can you see the? Okay, hold on. Sorry. Something is wrong. I stop share first. So for all the doctors, please use this QR code. It's only for doctors, yeah, the QR code. And use your phone to scan it with the MMA app. And if you can't, then I'll give you my phone number later to actually, can you see the QR code, everyone? Cannot?
I can't see it.
Can't see it. I do it again. Then. Something is always wrong. Okay, can you see it now? It's loading. Yeah. Okay, fine. So if you can't, we have to do it manually. I'll give you my number later. For all the nurses, this QR code is not for you. The QR code is for the doctors. So for the nurses, you have to go to Facebook, Beating Hearts page, look at the ECert registration form and register there. Now, the questions, now the problem is when I share this, I can't see the chat. Can you see the chat, please, Putra?
I can see it.
Can you please see the questions?
So let me read some of the questions. So question 1, okay, just now I showed an X-ray of a patient with an ACL tear that has a Segon fracture. So someone has asked, will this fracture be seen on a lying down knee X-ray? Because my clinic is unable to do a standing knee X-ray. So the answer is yes. It will be seen on whether the patient is lying or standing. It will be seen on the X-ray. So that's a simple answer lah. You can do a lying down X-ray, it's fine. Because there's a fracture there, the fragment is out, it will be seen. All right. All you have to do is you have to make sure it's a proper AP view and the leg is not rotated. Okay. Now question 2 is Dr. at Nabilatul is asking, Doctor, at what duration will an athlete get back to his or her sport post ACL reconstruction? Will it take years or on average only months up to a year? Now the standard answer to this question is about 6 months to 1 year. Now it depends very much on the patient themselves. Some patients are very, very motivated, and there's a case which there's a famous footballer by the name of Zlatan Ibrahimovic, and he had an ACL injury. He was operated, and he was back to full form in 6 months. Now I spoke to the surgeon who operated on him, and the surgeon said that there's nothing special that the surgeon did, but rather the reason why Zlatan went back to being able to score international goals after 6 months of surgery is that Zlatan himself was motivated to rehab himself. So I think that the simple answer to this is it will not take years. It takes usually an average of 8 months. But in some patients, they can go back to sports at about 6 months. But most of the time, it's between 8 to 12 months. So did I make it unnecessarily complicated? Maybe I'll simplify it saying that it's less than a year. If you're really, really dedicated, 6 months. If you're not so dedicated, about 8 months to maximum about 1 year. So the next X-ray Victor Lee has said, Dear Doctor, I would like to ask the suggested treatment for a partial ACL tear. This is very, very interesting. There are, I would say that it depends on, is this patient a very, very active sportsman or sportswoman? If he or she is very active, then I would suggest to get an ACL reconstruction, because the partial ACL tear is not going to heal. It's going to get worse as the patient injures their knee again and again. And having a partial ACL tear will predispose this patient to being injured again, because their knee is not as stable as before. It's kind of wobbly. So I would recommend ACL reconstruction. Sometimes we don't remove the ACL that is partially torn. Like for example, if the ACL is just partially torn, we don't remove it, but we do a procedure which is called an augmentation, where we create a new half of the ACL, because the ACL has 2 bundles actually. There are 2 bundles there. Sometimes only one is torn. So we keep the intact one, but we create another half, the second bundle. But if this patient is not a high-level athlete, if he or she is just a recreational athlete and not really that active, rehab alone is a good way to go. In fact, I would say I would try about 3 months of rehab before deciding to go for surgery in this particular patient, the partial ACL tear. I hope that answers that question. Oh my, the lights went off. Sorry about that. You can hear me, right?
Okay. What is the expected recovery time for the ankle? Have you done that?
Not yet. Okay. Ankle sprains usually recover in about 6 to 8 weeks. If it's a partial, because when I talk about ankle sprain, you're talking about a torn ligament. Now, torn ligaments, not including the ACL, heal in about 6 to 8 weeks. So the recovery time is about 6 to 8 weeks. But if this is a full tear, meaning the entire ligament is torn, then that may require repair. So what advice can we offer to patients to manage it at home? Okay, great question. Thanks, Eugen. The standard traditional thing that we talk about is RICE, which is rest, ice, compression, and elevation of the ankle. Now they have also included something called protected weight bearing, which means, that I showed you that there's a kind of a walking boot that can be fitted on in place of a cast. So that kind of walking boot allows the patient to start walking earlier, but it still protects their ligaments that is injured. So that's something that we can include. But if you're talking about patients to manage it at home, ice 3 or 4 times a day for about 5 to 10 minutes. Keep your ankle up on a pillow when you sleep or when you're sitting watching TV or something. Make sure your ankle is up high and not dangling down below, because that increases swelling and reduces the healing. Lengthens the healing time. So another thing is some rehabilitation exercises like calf strengthening exercises. You can ask the patient to stand at the edge of a stair and tiptoe, and then drop their heels down. So these are exercises that you can tell the patient to do to recover better from an ankle sprain. The next question by Dr. Adelina. I used to run about 100 kilometers a week. Okay, that's a lot. Recently, I had an acute pain in the medial anterior area of my left knee, and I was told I have massive OA and said my running days are over. Any comment? Okay, now the comment I would say is that, number one, we need a little bit more information, things like how old you are and your body weight and things like that. But I would say, knee osteoarthritis, definitely running 100 kilometers a week is a major load to the knee. Even if you don't have knee osteoarthritis, it is a major load to your knee. Now, I would say that it's best now at your point where you have been diagnosed with osteoarthritis, it's best if you can switch over to cycling, because cycling is an exercise that offloads the knee, and at the same time it improves the strength of the quadriceps muscle and the muscles around the knee, and that actually will improve the symptoms of your osteoarthritis, because it takes the weight off the cartilage and puts it onto the surrounding musculature. So if you can switch over to cycling for now, that would be good. Once you have strengthened your quadriceps muscles sufficiently with cycling, if you would like to go back to walking and gentle jogging, but maybe not 100 kilometers a week, you can try starting maybe around 1 to 2 kilometers a day and gradually work up from there. So I won't say that your running days are over. I would say your days of 100 kilometers a week are over, but you can gradually get back to running slightly at a lower capacity, not 100 kilometers a week. So I hope I answered that question. But at the same time, I think it's best if if I can have a look at your X-ray, I don't mind giving you my opinion on what your osteoarthritis is. I mean, what we can do to make it better. Now, the next question, Dr. Lee asks, what are the 4 muscles in the rotator cuff? So the supraspinatus muscle is the main one. That's the one that lifts your arm up onto the side. That's the one that's most commonly injured. The second is the infraspinatus. That gives external rotation of the shoulder. The next one is the subscapularis, that gives internal rotation of your shoulder. That's the one that lets you scratch your back. And the fourth one is the teres minor. The teres minor is less commonly injured. So most injuries in order are supraspinatus, subscapularis, and infraspinatus. That's where most injuries are. And of that, 90% of the ones that I see are supraspinatus. That's the one that goes up, which is why you will see that most patients with shoulder injuries have problems bringing their arm up above their shoulders. Let's see, Eugen is asking, is there a way in which we can identify the grade of ligament tear in ankle sprains in a resource-limited setting clinically? Very interesting question. I would say that if you have access to an ultrasound with a straight probe, not the curved probe that you use for obstetric scanning, it takes a bit of training to visualize the ligaments on ultrasound, especially when you're using a bigger probe. There are specialized probes for the ankle and things like that, but you can see whether the tear is a full tear. If it's not a full tear and the ligament looks bulky, you can compare the two sides on the ultrasound, let's say left and right. Now, if the left side, the ligament is about 0.2 centimeters wide and the right side is 0.4 or 0.5, then you know that that's definitely double the size of the normal ligament. I would call that a grade 1 or grade 2 tear, meaning that it's a partial tear. You may not be able to differentiate between those two. but you can differentiate between a complete tear and a partial tear with the ultrasound. Clinically, if you are looking at a complete tear, probably once the swelling has gone down, the patient will have an unstable ankle. So if you do a drawer's test of the ankle and compare it with the other side, it will be definitely more unstable. But there's no way to differentiate between grade 1 and grade 2 clinically, I think. There are certain ways, I mean, they have been described that when you check the drawer's test, whether it's a soft endpoint or a hard endpoint, but I think that's pretty difficult unless you're doing nothing but examining ankles every day, then you probably will be able to differentiate. But if not, then I would still go for an MRI. I think that's my advice.
Okay, I
Last question.
Sorry, there's a question on from Facebook. I don't know how about patellofemoral pain for runners? What can we do about it?
Excellent question. Patellofemoral pain is very common, especially in younger ladies. That doesn't mean other people can't get it, but it's most common in younger ladies. Now, what happens is young ladies usually have a weak quadriceps muscle. And specifically, there are, quadriceps means 4, right? Quadriceps means there are 4 parts of that muscle. So we are talking about the vastus medialis obliquus, or the VMO, which is on the inner side of the thigh. So what can be done for that is you increase the strength of the VMO muscle. Cycling is good for that, but there are specific exercises that strengthen the VMO. Some of them include doing a squat or a half squat and putting like a basketball or something between your knees and holding it there and counting to about 10. Repeat that maybe 20-30 times a day. That's good to strengthen your VMO, and that will improve patellofemoral pain. The other thing is, commonly patellofemoral pain is because of a cartilage injury. So if you are examining this patient, what you do is you ask the patient to lie flat, relax all their muscles, and then you probably can move the patella from side to side. Once you can do that, you displace the patella slightly to the side and you hook your finger underneath and palpate the cartilage. If there is pain when you palpate the cartilage, there's probably a cartilage injury. That may require things like a PRP injection, hyaluronic acid injection, or maybe like the procedure that I showed, cartilage repair procedure. So that's patellofemoral pain. I hope that answers that question.
I think so, because there are more and more questions coming. I think we need to bring you back for another session.
Okay, I'm most happy to do that.
Okay, we are going to do, it's been very good. So which one are we doing now? Dr. Lau? Okay, last 3 questions, no more, because we are very...
Okay, let's go from, somebody asked about the compression in the rise for the ankle injury. Is it advisable for the patient to apply the compression bandage all the time for 6 to 8 weeks? I would say for the first 2 weeks, yes. After that, they can gradually wean themselves off the compression bandage, or actually what I was mentioning earlier, that there are specialized braces for the ankle. If you like, I give you some of the companies that have that. And for the first 2 weeks, I ask them to wear it 24 hours a day. After that, gradually, when they're sleeping, then to take it off, and then later on, after 6 weeks, they wear it only when they go outside for activities. So that's that question. Dr. Lau asked, post ACL reconstruction 6 months, will PRP or hyaluronic acid injection accelerate, recover, or slow down knee OA? Okay, good question. ACL reconstruction does not slow down knee OA. Once you have an ACL injury, you will develop knee OA in the future. That is a given, whether you have the reconstruction or not. The reconstruction is to help you go back to sports and not feel that instability or that wobbliness of the knee. But the knee osteoarthritis process will have begun. Depending on the age of the patient, knee osteoarthritis will set in earlier than normal. So giving the PRP, giving the hyaluronic acid, it may slightly improve the symptoms, but it will not really slow down the osteoarthritis. Once you have damaged your knee, you cannot escape the consequences, which is osteoarthritis. So you have to be prepared for it. You can strengthen your muscles to reduce it, but you cannot avoid it. And PRP and HA probably will improve the symptoms but will not reverse the process. Dr. Hafiz asks, hi doctor, is there any suggested lifestyle changes, footwear for unstable ankle? Okay, great. I think that as I was mentioning to Dr. Betty earlier, that if you're going hiking, it's good to keep an ankle support in your bag. You can always use that. Maybe another thing I would say is that your shoes should be, you don't wear too low shoes when you go hiking. That's why they actually have hiking boots and things like that, because it provides a better support for the ankle because it's higher. So maybe hiking boots will be good if you're talking about hiking. Of course, not all the time, but during hiking. Is this the last question?
Yeah, we take the last question. That's all. Just
All
one
right.
more question. If you want to answer, you can answer. It's
If you
on.
have time. Okay, I'll answer this one. The cold versus
Yeah.
warm compress.
The
Any
last one.
specific?
We won't take any more anymore.
All right. Okay. Cold versus warm compress. Any specific duration for rice treatment before changing to warm compress? Any proven data? I don't think there's proven data about that. However, warm compresses are used in chronic injuries because if there's an acute injury, there's a hematoma, there's bleeding, you put something warm there, it's going to worsen it. So you put ice to reduce that. But once it's past the healing phase, which means that it is 6 to 8 weeks, if the swelling has already gone down, but you still have pain, you can apply a warm compress. But usually when do I ask to use a warm compress is when there's muscle spasm. So after 6 to 8 weeks in a splint, for example, or some kind of brace, the patient is going to have calf muscle tightness and things like that. So for that, at 6 to 8 weeks, I will start the warm compress if the patient needs it. But again, instead of the warm compress, I would still recommend stretching exercises and strengthening exercises over the warm compress. No proven data about that. I haven't come across it, but if I come across it, I will tell you the next time.
Okay, the next time we will do case study of all your cases.
Okay.
Yeah, then we will show them, you know, how they got back to normal activities. Why do we do that? I think because
okay, I'll have to take the patient's consent, but yes.
Sorry?
I'll have to take the patient's consent, but yes, I will try to do that.
Oh, no need to take photo, like maybe, yeah, maybe if you can, but we see how it goes. Think about it.
All right.
But we definitely would like to invite you back again.
Thank you so much.
Yeah, because it's been a very interesting, and you're very good at imparting your knowledge to everybody. You have this teaching ability. So I will stop the live stream first, and then I will stop